Okay, folks, welcome back again. Now we're going to go into the end-of-life issues, bioethical issues and the end of life. As always, we begin with a little prayer. In the name of the Father, the Son, and the Holy Spirit. Blessed Trinity, we love you, we adore you, and we thank you for your many blessings, Lord, for the gift of life and for having us here together once again to study these bioethical issues of human life as we transition now to end-of-life issues and the multiple issues that come up in this area that are delicate because we're talking about the lives of real human beings and also their loved ones, how everyone is affected with these delicate issues. As we start our Lenten season now, we ask your Holy Spirit to inspire us, to guide us, to enter into this time of preparation for the Easter joy of the resurrection of your Son and the promise of resurrection for each one of us, which really puts the end-of-life issues in context that as long as we may live, we are here for a time, Lord, but that our ultimate destiny is eternity with you in your glory in the beatific vision. And so once again, we ask for your blessing and we pray in a special way for all those who are in need of your divine mercy. In the name of Christ, our Lord. Amen. Son, Holy Spirit. Okay, so let's go forward. We're going to be looking at these bioethical issues at the end of human life. And also in the second part of today's lecture, we're going to look at one fundamental principle that I find very useful, which is the distinction between assisting or substituting vital organs. The first thing we're going to look at is vital organs themselves, all right? Now, I want to point out as we transition from the bioethical issues at the beginning of human life to the bioethical issues at the end of human life, there is one drastic distinction between these two realities. And it's this, that whereas the bioethical issues at the beginning of human life, we actually at the very beginning, to establish the beginning of life, we're dealing with one cell, a single cell, the fertilized egg, which we call the zygote, right? And the zygote is either dead or alive, it's either human or not human, etc. So that establishes the groundwork, if you will, for doing the bioethical analysis on all of the issues at the beginning of human life, when human life begins. And from the scientific evidence, from nature, we can say unequivocally that it is at fertilization, at the completion of syngamy, right, when the two nuclei fuse to establish diploidy on the zygote. Right, so that's a single cell. Whereas now fast forward to the end of human life, or all life on Earth, right, except for unicellular organisms, toward the end of life, typically we have trillions of cells. Even when we're born, we already have trillions of cells, right? And you know what? These cells, they don't all die at the same time. As obvious that that may seem, that presents bioethical challenges when we're talking about the end of someone's life. Because if we take it down to the cellular level, we know that with these trillions of cells, they will die at different times. And some may die within minutes of each other, but others will die within hours, days, or maybe even weeks within each other, all right? And typically, what is the organ that fails fastest is probably the brain, the nervous system, which is the most specialized and so forth. So maybe within 5 to 10 minutes, a person without oxygen to the brain is going to be brain dead, total brain dead, okay? But the heart may go on for a little longer, and the liver may go on for maybe a few more minutes or maybe hours. The kidneys may go on also, even putting out urine for several hours after we have an actual cadaver because the brain is dead and the heart has stopped and so forth. The nails, I've heard that nails continue to grow and hair continues to grow in the cadaver inside the coffin, right? For days. But of course, what we have there is just tissue growth, but we don't have a living organism as such. The integrity, not only the physiological, but the ontological integrity of that person has been compromised and lost. So now we're dealing with a cadaver, all right, who continues to grow organically in different parts simply because the trillions of cells, they don't all die at the same time. All right, so it's just a biological fact that we have to deal with. From that perspective alone, it makes it a little more complicated and delicate at the end of human life. And therefore, bottom line is we have to go case by case. You know, it's like they say in medicine, you've seen one patient, right? And therefore, we have to go case by case. Even so, this is not situation ethics where our values and principles will shift from patient to patient. No, there are certain fundamental principles and values that we can hold across the board that we can sustain to help us make these bioethical decisions at the end of human life. And this, to me, is the big contribution and the beauty of Catholic bioethics, that in spite of the fact that each person, each patient, each dying person is unique and different even in their dying process from one to another, we still have certain fundamental principles that are applicable, are universal, and are applicable in particular situations where people are actively dying, all right? Transitioning to that process of dying and so forth. And so to me, again, the universality of Catholic bioethics shines in this aspect that we have these fundamental principles that are applicable. And you'll see they are really, again, common sense. We just need to stop for a moment and reflect and see how it makes sense. It's logical. So these are arguments, like I say, these are arguments of logical consistency, right? These are reasonable arguments. The same that we did with human life when we established when life begins as human, then the logical conclusions that come from there of respect for that life, right? Well, the same at the end of a human life, we're going to come up with, I'm going to propose to you certain fundamental principles that are applicable and are reasonable. They hold as long as we understand, for example, vital organs, okay, and what they represent in the body. This is not only structurally, but also functionally. All right, so let me move forward then. And we're going to look today specifically at the vital organs of the body. And then briefly, to ground that, because the Catholic bioethics is also evidence-based. Sorry, I forgot about the light. Yeah. Catholic bioethics is interesting that on the one hand, it appeals to very high values and high reasoning, and at the same time is evidence-based, right? So it's not fideism, that is just because the Bible said so or because God said so, either in a dream to me or again through the Bible. No, it's not fideism. Rather, it's reason and faith collaborating and working together, all right? The complementarity between reason and faith. So we're going to look at vital organs. We're going to look at major causes of death in the United States to ground those vital organs. And then finally, this bioethical principle that I'll introduce today, which is the distinction between assisting or substituting vital organs, okay, and the implications of that distinction. What does it mean functionally to assist or to substitute one or more vital organs for this particular individual in front of me now? Okay, again, if you have any questions or comments along the way, you can stop me. Just a little tiny review of the biology as we take it from the beginning of life to end of life, right? The organic process of, to be clear, the basic unit of life, organically speaking, biologically speaking, is the cell. But keep in mind that the cell, unless we're talking about a unicellular organism, you can give me an example of a unicellular organism? Again? Bacteria are unicellular, right? And with a defined nucleus, eukaryotes. Remember the amoeba, paramecium, euglena, so all these unicellulars, right? They are, the whole organism is defined within that one cell. But the ones that are not unicellular are multicellular, and the vast majority of organisms that we actually see in plain sight are multicellular, right? And therefore, the cell, even though the cell is the basic unit of life, typically a cell is not just out by itself, all right? Cells come together, they cluster together, and cells, as they cluster together, they form tissues. So cells with similar function form tissues. And then tissues with similar function form organs. Organs with similar functions form systems. And then there's a shift. Systems with different functions, integrated, constitute the whole organism as such. Okay, so again, let's go over that for a moment. Cells with similar functions form tissue. For example, the skin, all right? There's the epidermis. First, there's a whole layer of dead skin that we have that is actually part of the protection. It's kind of the painting, if you will, on the building of our bodies. So there's a layer of dead skin, but then there's a layer of live skin, and that's going to be the epidermis, right? That's a tissue. So those cells are epidermal cells, and they have a similar function, basically to be the front line of protection for the body from foreign objects. And so that's a tissue that has cells of similar function. Then below the epidermis is the dermis, the dermal layer. It's a little more pinkish and tender, right? When we get a scrape or a cut or something, we see the dermis underneath, very pinkish. There's no melanin on it. That's why it's pinkish in color, because actually the cells themselves are transparent. And what we're seeing there is just the capillaries, the sum of the capillary regions with the RBCs, with the red blood circulating, that becomes pinkish in color as the light diffuses through the semi-transparent cells, all right? At any rate, that's another layer of tissue, which is the dermis. And then below the dermis, we find another layer, the conjunctive tissue, and then the adipose tissue, otherwise known as fat, and so forth. We keep going layer by layer down into the body. Eventually, we get into the muscle tissue, and deeper in, we get into the bone. Those are all tissues, right? As they come together, these tissues of similar function then form organs. And then the organs that have a similar function also, they will form a system, what we call organ systems. And we have about a dozen organ systems in the body, depending on how one defines them, either structurally or functionally, all right? So for example, who can give me an example of an organ system of the body, of the human body? Cardiovascular, right? Yeah. Or that's defined, see, that's defined functionally. If we were to define it structurally, we could talk about the circulatory system, because the heart itself is a muscle, which would belong to the muscular system, right? But if we define it functionally, then some of these organ systems blend. For example, the musculoskeletal system also. That's defining it functionally by way of locomotion. But structurally, we can talk about the muscle system, smooth muscle, striated muscle, structural and cardiac muscle. And we talk about the bone, the skeleton itself, all right? So again, about a dozen of these systems, you notice they're all constituted by organs that have similar function. Digestive system. The organs in the digestive system, they have similar function, beginning with, probably the mouth, the tongue, and the throat, and the esophagus, the stomach, small intestine, large intestine, colon, etc. Right? See these organs? But then the liver will also be part of the digestive system and so forth. But it's also functionally part of the circulatory system, because it also filters the blood and processes, metabolites, medications, for example, drugs, right? And so forth. Okay, my point is that we end up with about a dozen organ systems: circulatory, respiratory, nervous, skeletal, muscular, the immune system, right? is another one that is diffused throughout the body. The circulatory system itself is a liquid system, right, which is the blood, because the blood has at least 3 different tissues that are very evident to us. The red blood cells, right? They are cells of similar function, so they form a tissue. We can talk about the tissue of RBCs. The white blood cells have a different function, but they're part of the circulatory system. And then there's platelets, which are also another category of cells that are involved not in transport of gases, not in the immune system directly, but they're involved in making a scab. And then there's the serum fraction of the blood and so forth. So you see that even blood as a system is a liquid organ system of the body, etc. Then one that integrates all of the body is a very special system. Because imagine if we had all of the organ systems laid out here on top of the tables, we have the circulatory system, respiratory, digestive, nervous system, all the organ systems laid out, but separately, you know, if somehow we could keep them alive, hypothetically, we wouldn't have an organism, a functioning organism. We wouldn't have a functioning human, right? They have to come together and interact in a coordinated fashion so that they complement each other. That's why I say when we go at the highest level from organ system to organism, now we have organ systems that have different functions, specialized functions, coordinated together, they form the organism. And the one system that integrates all the other systems of the body is the brain, the nervous system as a whole. Brain being the main organ of that system. See? So just to point out the whole hierarchy from a single cell, living cell as the basic unit of life, but if we don't put that cell in context, we don't really have a functioning organism, a functioning human being or any other organism that we can think of, right? So yes, we say that the cell is the biological unit of life, but that's very hypothetical and simplistic. We have to put that cell in context because typically we're going to be talking about specialized cells, differentiated cells. All right, so in what tissue does that cell reside? And in what organ does that tissue reside? In what system does that organ reside? And then in what organism as a whole? So the level of systems, organ systems, there are organ systems with different functions that are integrated by the nervous system to form the whole that we call a living organism, an individual, in this case, you know, a human being. All right? So it's just a basic review of trying to get us thinking functionally, right? Because even life as such is not really a structure, it's a function, right? We are functionally alive, day by day, minute by minute, year by year, etc. Okay, so that's just a little tiny review there of organic life. Oh, and then the other one, so it's interesting also, I like to just muse on these parallels, how the system that coordinates all the other systems and that integrates all the other systems of the body is the nervous system, right? Which is really at the core, if you think of the body physiologically, is the innermost system that we have really, beginning with the brain, which is inside the scalp, inside the skull, inside the meninges, and then it tapers down into the spinal cord, which is also inside the vertebrae, inside bone, all right, all the way down to the tailbone, and then the appendages and so forth. So the nervous system, which integrates and integrates the rest of the body, is at the core of our body, the kind of the physiological center of it. But then the other system that keeps our body together and serves as an envelope for the body and distinguishes us very truly, very physically, is a boundary between self and non-self. You know, what constitutes me as myself in contrast to the immediate environment that surrounds me. the air molecules that are surrounding my body right now, and then beyond that, the rest of the universe that is not me as the self-identity is the skin, the integumentary system, which is kind of the envelope, right, of the body. And so we can talk about self, really, and the self, which is delimited by our skin. And it's a very real physical boundary between what is myself and what is not myself, which doesn't belong within me because it will be a contamination, except for the systems that are able to receive stuff from outside, like the respiratory and digestive system and so forth. You think, oh, and then if we trace those two systems, the nervous system and the integumentary system, right? If we trace them to their origin embryologically, where do they come from? If we go to the gastrula stage, remember when we have the 3 germ layers of ectoderm, mesoderm, and endoderm, which are the 3 germ layers that make up all of the organ systems in cellular differentiation. Early on, we're talking about the first week of embryonic development already. After implantation, after the blastocyst implants, then he or she goes into the next stage of gastrulation, right? The skin comes from the ectoderm, for sure, but also the nervous system comes from the ectoderm. Is that pouring in, that invagination of the central groove? So it's interesting that both the outermost and the innermost system of our body, which have those 2 particular functions, come from the same germ layer originally. Talk about interesting, elegant design, huh? And the economy, we can talk about the economy of nature. How interesting how all that comes together. Okay, enough musing. Let's go forward now with an actual look and review of the vital organs. Because we have many organs in the body, and many of them are important organs. They're all important, some are more important than others, but not all important organs of the body are vital organs. For example, the eyes. Certainly, we would all consider our eyes very important, right? And it's estimated that maybe 90% or more of the information that we have in the brain actually comes through our eyes, normally, okay? And yet, they're not vital organs in the sense that we can live without the eyes, right? In fact, blind people are able to live and have a life and are fully human otherwise. So not all organs in the body, even important organs, are vital organs. Another one is the reproductive system. The entire reproductive system, which is obviously very important, but it's not vital at the individual level. Evidently, men and women can live without the reproductive system and still have a full life. So the reproductive system, in a sense, is vital for the next generation, but not for the individual who carries them, who bears those organs, all right? So that takes the discussion at the level of the population. As long as someone in the population is reproducing or procreating, then the next generation is guaranteed, if you will. But at the individual level, it is evident that we can live with the reproductive system, even though it's certainly a very important system of the body. Okay, so which are these vital organs? Specifically, we can go down the core of the body, down the center from the head to the hips, and see what's there that are vital. Some are paired organs and some are not paired, okay? So starting from the top, literally, the brain, and the brain stem separately as 2 distinct organs functionally, all right? One of the constant efforts of this entire program is to get people to think functionally, because we don't see functionally, we see structurally, we see structures. I see a computer in front of me, but unless I know how to work the computer, I really don't truly know what it's for, the function, all right? But so we normally see structures, but then we have to translate that through an active process of thinking into, well, what is the function of the structure? So the brain and the brain stem. This is important also because we know that whereas the voluntary movement and thoughts and voluntary activity of the human and other animals occurs in the brain, in the cerebrum, the involuntary activity occurs in the brain stem. And some of these involuntary activities are vital functions, like, for example, heartbeat and breathing, respiration. Okay, so circulation and respiration are maintained basically by the brain stem. And it's a good thing because that way we don't have to be telling our hearts constantly beat, 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 60 times a minute, every minute of our lifetime. It would be exhausting. So that is done by the autonomic nervous system that is wired into the brain stem. And so the brain stem has its own function like that, independently from the thought process. And also the breathing. So we know that the breathing is a nerve, both with voluntary and involuntary nerves, so that we can breathe on purpose. I can take a deep breath on purpose. I can hold my breath on purpose, but only for a while. Because eventually the autonomic nervous system will kick in, especially with the bellows, with the diaphragm, and make those lungs breathe on a normal rate. And again, that's a good thing because then we can sleep at night and we don't have to be telling our lungs, breathing consciously 20 times every minute to make the lungs breathe. So all that occurs in the brain stem, and as you can see, they're vital functions, and therefore this is going to become very relevant when we talk about brain death, partial versus total brain death, right? Which partial is not acceptable bioethically, but total brain death, yes, including the stem. Okay. So that's a little anticipation when we talk about the determination of death. Then lungs. You notice both lungs, because again, functionally, people can live with one lung, all right? They're not gonna be running the marathon, they're gonna have a sedentary life. People can live with one lung, so we have to functionally include them as vital organs, both lungs. The heart, which is not a paired organ as such, even though it has a bilateral symmetry of sorts, but is a single organ as a whole, a functioning organ. And the liver, which also has several lobes, 3 lobes, right? And we know that people can live with perhaps up to 1 lobe less and still function. So the liver, in its entirety of the lobes. The pancreas, which as small as it is a vital organ. The stomach also as a whole, in principle, is a vital organ. Then we have to bring this list up to modernity by medical intervention, how some of these vital organs can actually be replaced. The intestines, small intestine, large intestine as a whole, because we know again that people can live with sectored intestines, especially in the area of cancer, surgery. Again, the kidneys, both kidneys, because people can live with 1 kidney and keep going. So functionally, for vital organs, we include both kidneys, right? And that's really about it for vital organs as such. Now, to ground this in what I say evidence-based, this is a list of the 15 major causes of death in the United States, as documented by the CDC, which is the Center for Disease Controls and Prevention at the federal level. This is part of one of the branches, is vital statistics of the nation. So you can see the list. Number 1 is always the heart, diseases of the heart, accounting by itself more than 1/4 of the losses of the deaths in the United States. Second to it, fairly close, is cancer. But of course, this has to be in the plural, right? Because there are many different types of cancers, depending on what organ it's affecting and whether there's metastasis or not. In principle, this could affect any vital organ, any of the vital organs. And then stroke or diseases of the brain, it drops down to less than 7%. All right, so the first two together already make up 50% of all the deaths in the United States. Pretty drastic. And these, of course, are premature deaths, right? These are premature deaths because a natural death we would consider in the around between 78 to 82 years of age, on average around 80 years of age. It's not going to be what is the most typical age for heart attack. The window is the 40s and the 50s, right? Between 40s and 50s and more on men. So that's definitely premature by about half of the lifespan of the man, which is about 78. Okay, so these are premature deaths until we get to number 8 here. Anyway, I'm anticipating myself a little bit. Number 5 is accidents. And this one is very, very preventable in principle if we just were to behave better. So this is totally behavior induced, right? Accidents, by definition, are just being careless one way or another. And typically, the typical accident is a car accident. People are afraid of flying, right? Because it sounds very scary to be up there thousands of feet above sea level, and yet it's much more dangerous to drive in any city, especially the city of Miami, than flying. There are many more accidents, car accidents, than there are plane accidents, and it's just human behavior. So that's number 5 on the list, but you see at this point we're down to less than 5% or so, so the percentage has dropped quite a bit from the 2 big ones of cancer and heart attack. Then diabetes is a major one, which increasing, and this is also partly driven by behavior, right? Because of our lifestyles, on the one hand, sedentary lifestyles, on the other hand, not too good eating, so forth. And that one involves the pancreas. Then pneumonia, influenza, similar to diabetes, around 3%, just under 3%. That one affects the lungs primarily. Now we hit finally the first disease of old age, typically, all right, Alzheimer's, affecting the brain primarily, the vital organ of the brain. That's less than 2.5%, okay. The others are less than 2%, a very small fraction of the total deaths in the United States. Issues with the kidneys, septicemia, which is blood poisoning, and that's affecting the vital organ of the blood as a whole. Suicide, again, totally behavioral. This is another one that is absolutely behavioral. As tragic as it is, it's a relatively small percentage of the population. This, of course, could affect any vital organ, but typically it's the brain, unless it's medically used medication. But even functionally, think about what just 1% of the population means. We're about 320 million people in the United States. So that's 3 million people annually in suicide. Okay, so even though it's only 1%, but when we translate that into a real number, that's 3 million people every year, okay? This is not just attempt. This is not just ideation. This is succeeded at it. So this speaks of, you know, the social environment we live in and the stress and lack of support for some people and so forth. All right, so more, it makes a distinction here between cirrhosis and the other issues of, so this is on the liver, yes, cirrhosis of the liver. Of course, a lot of that is driven by alcohol, unfortunately, just a little over 1%. Hypertension, affecting the kidneys primarily, less than 1%. Parkinson and other old age disease generally is less than 1% again. And homicides, killings, again, less than 1%. And all others then, so all these add up to about 75%, about 85%, other 85%, and the rest are 16%, 17% of the population. What's interesting is that the first two, just to highlight, the first two comprise 50% of the population. And I think the first five then is 2/3 of the population. Where did I put it? Yeah, the first five then are 2/3. So the really cluster is a very skewed curve. It's not very homogeneous, all right? So if one were to prioritize, one could look at these five, which one way or another have a very big social behavioral component, accidents for sure, but also when you think about heart attack, typically is pressure, right? Excessive pressure. And tumors, there's a link now between the immune system and the onset of tumor, of cancer. And there's also a link between a suppressed immune system stress. Stress suppresses the immune system. There's some studies on that, right? There's a link there. So we can trace one way or another. These have to do with human behavior. So we could better our lifespan if we move toward better behavior also, in general, more healthy behavior, right? In the full sense of the word. Anyway, the main purpose for this list is not to be morbid or anything like that, but rather to see that of these 15 major causes of death in the United States, they all involve at least one vital organ, if not more. So it just grounds the fact that these are indeed vital organs for the human, and they are very real in the sense that typically when a person is dying, it's because at least one of these vital organs is failing. Then the next question is that vital organ failing irreversibly or not? Okay, so from the bioethical perspective, the issue is this organ failing irreversibly or not? In other words, is there still some cure, or are we down to just care, right? The distinction between cure and care, which we'll talk about in later sections, but just to introduce the concept. All right, next. So any questions here? I think we're pretty, oh yes, the other clarification I need to make on the vital organs is that whereas some of these vital organs are not yet replaceable, medicine has been advancing to where some of these are already replaceable, at least for some period of time, at least partially, all right? So, for example, it's still experimental, but the heart, there are heart valves, there is also an artificial heart that is still experimental and so forth, but it's getting, it is?
I have patients
fully artificial heart, huh? Tremendous, amazing. But I would think that that's still an experimental protocol, no?
Yes, I mean, it's a very rigid protocol.
I can imagine, and
Like
really? It's amazing, it's tremendous. Yeah.
Yes,
They're
but I mean,
functioning?
I see them for a brief period of time and then they go back to the hospital and I don't know what.
Yes, you lose track of them, right, exactly. So it's, I would think that it's still very experimental, very promising, and especially as technology is just advancing, it's galloping our contemporary technology, including nanotechnology, so it's very promising. When we get to the transplant section, I have a friend who has a heart transplant, but it's an organic, it's a cadaveric transplant, right? And he was on the waiting list for 10 years. It's just amazing. And now he can even dance the cumbia. He's Colombian and he loves it. So. Okay, the liver that I know has not been replaced yet, but we can live with fewer lobes than the 3. The pancreas, no, there are transplants of the pancreas, but I haven't heard of an artificial pancreas yet. Stomach also can be resectioned and so forth, and clamped. So a very small section of the stomach, but some of it needs to be functioning, right? When they do the stomach, the bypass, it's total bypass. It's,
they live like a quarter-sized piece of stomach.
That's it, huh? Yeah. Okay, is that just mostly for passage of the bolus, or is it because there's some minimal function that is needed there? Maybe some gastric juices that need to be received. Yeah. Okay, so so the gastric juices, I imagine, all the bile.
Yeah. The purpose is to lose weight.
It's the main purpose, yes, right. But I hear it's a very delicate operation and risky. It's high risk, very high risk, right? Yeah, not everyone qualifies. I know a priest who had a gastric bypass and he almost died from it. Yeah, very risky. But it's there. Anyway, the intestines can be sectioned, but not the whole intestine for sure, either the small or the large. Kidneys, for sure, 1 kidney, and then the dialysis, which I'm going to talk about now, as an example to illustrate this, this principle of assisting or substitute. All right? Yep.
For ascites, is that often associated with cirrhosis when the patient has ascites in the body?
So I'm not too familiar. I know it's in the abdominal region, but ascites is something with tissue that is inflamed, or how does, what is the etiology?
Yeah, ascites is the result of extravasation of fluid into your abdomen, the peritoneal cavity. It's usually associated with cirrhosis because there is hypertension of the circulation of the liver.
Can it reverse? Can it go away?
If you control, usually it's reversible, they usually take it out. They do draining the breast.
They drain.
But when you can control it also with some diuretics or trying to control the pressure of the circulatory system of the liver.
Of the liver.
And in some other cases, it's related not necessarily to the liver, but then they have like overload of fluids, like somebody in congestive heart failure that have severely malnourished, their space and stuff. There are other conditions that can lead to ascites.
So it could be, they have fluid in the lungs too and in the heart?
Well, yes, ascites is in the abdomen, and then you have pleural effusion in the lungs.
So it could be together.
Yes.
Yeah, so it's multiple. Yeah. Yeah, these are conditions, there are protocols for it, right? But they're rigorous protocols, and it depends on what's the cause of what's the prognosis, right? How successful it's going to be, or how far along is it? If it's chronic, if it's chronic cirrhosis, then we're talking about a liver that is dysfunctional and is falling apart, essentially. So it really depends on each patient, right? How severe it is.
Also, probably another high cause of cirrhosis is hepatitis C.
Yes, that's right, which I hear now there's a cure.
Hepatitis C.
Let's see.
You have idiopathic, which means no etiology primary. Which is hepatitis C, yes.
Can be, right? It's a virus. Right, it has to be direct contact with the fluids, with body fluids, and typically the blood, right? And it's a virus. It's a hepatitis virus that attacks the liver specifically. But I hear now there's also some people, there's cure for hepatitis C. It's amazing, yeah, because a cousin of mine had hepatitis C. Apparently, as far as they can tell, they can trace it to some transfusion that she received at one point and developed it, but now she's cured. It's amazing.
My mother too at 8.
Yes. Really?
At 8, she was cured for hepatitis C.
Tremendous.
With one of these new drugs.
Yes, it's a whole protocol. She didn't go into details of it, but it was pretty extensive. Yeah, it was very.
It was like $5,000.
Really? Wow.
That's what the drug cost.
Yes.
It's covered by insurance?
It's,
most insurance are because it's better to cure it than to pay for the care of that patient. So
Right.
it's becoming more. There's some others that were approved, but the newer ones that are really more effective,
yes,
then they're now more
beginning to cover it.
coverage has improved or the drug companies have an assistant, like my mother got into the assistance program, so she didn't pay for it.
Oh, wow, tremendous. Yes. Yeah, that helps the insurance company also validate the numbers and things like that when they do their statistics. But yeah, so it really depends on the insurance coverage that each individual has, right? Mm.
I have a question.
Sure.
Is it true that if you have like cirrhosis because of alcoholism, you don't get like to be in the list of the transplant?
No.
No, it's not true. It's not true.
Yeah.
I mean, the reason doesn't matter. You just have the right to be in the list.
I think,
They can qualify.
well, I just did the
Rotation, right?
rotation clinic,
Yes.
they look at the whole picture and you know, look at the social structure as well. And they would include some.
Yeah.
And the functioning individual, I guess. I have been a recovered alcoholic.
Right.
You know.
No, I just watched it on television and I was like,
Oh, yes?
this is true. I mean,
Wow.
but
Yeah.
they told me that
Yes, so for the sake of the recording, the question was, in case it was not heard, if a person with cirrhosis of the liver who is an alcoholic or has been an alcoholic, if they qualify for the transplant list, right? First of all, I don't think there's really a right as such, like a civil right, you know, like a right to drive with a driver's license or something like that, okay? So these transplant lists are, first of all, they're pretty extensive. I know more about the kidney transplant, but I know that the transplant list for the kidney right now is about 90 to 100,000 people on it. So it's huge, it's immense. And the waiting time is years typically, all right? But like you say, Monica, it's the whole picture of the individual patient, right? Including their social behavior, their background, the compatibility, the match. I mean, there are many, many factors that go into it. So that by itself, I don't think would be, and you say that in itself is not a disqualifier, but maybe some other things. Maybe one collateral of that is that they may be what is called non-compliant. Non-compliant then is a big red flag for transplant people, for transplant institutions. Non-compliant means that the patient is not following the instructions on taking the medication, watching their health, you know, eating the healthy eating habits, the exercise that they can do it, monitoring and minimizing their intake of alcohol and so forth. So from that angle, if they're non-compliant, then that's a big red flag for transplant, right? Because obviously everything else being equal, you have a person who is compliant and another who's not compliant, who deserves this the most because they're very practical. Exactly. They have a concern that the organ will actually, after the transplant, that the organ will have a chance to give this person, you know, a healthy life. So that's that compliance thing. I know about it from the kidney transplant perspective. Okay. So we see this. Now, this distinction, let's say, has a lot of bioethical potential because it can determine for us whether there is an ethical obligation, a bioethical obligation, to maintain someone alive on life support or not. Again, keep in mind that this is at the end of life, all right? So a person may be dying, and whether we maintain that person on life support or not, to me, this is a crucial distinction between assisting or substituting a vital organ. So staying still at the level of principle, think about this. The basic statement here is that there is no bioethical obligation to substitute vital organs. But there is, in principle, a bioethical obligation to assist vital organs. So again, there's no bioethical obligation to substitute vital organs, but there may be a bioethical obligation to assist vital organs. So looking at that functionally, what does that mean in real life for this particular patient. Imagine, this may sound a little difficult to swallow, that there's no obligation to substitute vital organs. But really, imagine if we had a moral obligation, a bioethical obligation to substitute vital organs. Every vital organ is going to fail sooner or later, right? So if we had the obligation, the bioethical obligation to substitute vital organs, it's untenable. It's not possible. We would have to substitute every failing heart, every failing brain, every failing liver. It's not sustainable, absolutely. Therefore, it is logical to conclude that there's no bioethical obligation to substitute vital organs. One may do it, but then that's called heroic means. Or in bioethical terms, that's going to be extraordinary means of life support. Extraordinary means of life support. That's what it's going to be. When we substitute vital organs, that is extraordinary means of life support. It may be done by heroic means, especially if the prognosis is good, right? If there's a hope of recovery. But strictly speaking, it doesn't obligate. Whereas when we talk about assisting vital organs, in principle, yes, this is what we will call standard care. All right, standard care, which is assisting vital organs, especially if there is a positive prognosis of the person recovering. We want to give that support to the vital organ temporarily until the pneumonia or whatever other, the cirrhosis, whatever other illness is overcome. All right, so in principle, there is an obligation to assist vital organs. Yes. So, before we go more deeply into the consequences of this principle, which we'll see in later lectures, I just want to give some examples on how to distinguish between assisting or substituting. At least on three major organs, three vital organs, the kidneys, the lungs, and I think it's the liver, yeah, the heart, okay? So kidneys, lung, and heart, let's look at them. Dialysis, we're all familiar with dialysis, somehow we've heard of it. It's a big machine, as you can see here, which again points to the elegance of nature. Imagine, this is the machine that substitutes our kidneys. And the typical kidney is about the size of a fist or less, our own fist, right? It's the size of our kidney, even less than that. And even just one of those is sufficient to do what this machine does.
There's much smaller now.
Yes, they are smaller. And in fact,
more compacted.
super compacted, yes, yes. Yes, right. In fact, there's one that is portable, right? And they can use at home. There's one that can be done overnight, I hear.
Peritoneal dialysis.
Peritoneal, yes, okay. Yeah, but what I want to point out basically more than the actual size of the machine itself, but the functionality. So the function is evidently takes out the blood of the patient, filters that whole blood through a filtering system inside, and then pumps the clean blood back. What is being filtered? What is being filtered is the toxins of the blood, right? Which is mostly ammonia, nitrogen waste, which is the breakdown of metabolism, the breakdown of proteins, mostly proteins, okay? And nitrogen in liquid form is yellow, and that's why the urine looks yellow. But notice this, while the machine is filtering out that toxic waste in our blood, that toxic waste is not just in a solid form, all right? It's not little cubes of nitrogen or waste that comes out, rather is dissolved in the liquid, which is water. And we are 80, 90% water, depending on how old we are. We tend to dehydrate with age, lose water. But basically, we're mostly water, just H2O. So internally, it's very much a liquid environment. It's this liquid soup that is metabolizing, all right, which we call life. So what I'm trying to say by all this is that in order for the machine to extract the metabolic waste, it has to also extract water with it. It's extracted in a liquid fashion, which means that this machine gets rid of that water from the body, and therefore it plays with the osmotic pressure of the body. Osmotic pressure is the amount of water that we have inside the body, which keeps a certain pressure. Okay? All this to say that these machines are delicate and sophisticated, and if they malfunction, they can cause hypertension or a drop in pressure, which could cause a heart attack. The person could go into cardiac arrest. And therefore, as I understand, people who go on dialysis, every time they go on dialysis, they have to sign a release form and a consent form that they accept the risk and the danger of going into cardiac arrest during the dialysis process. Okay? Some people are awake, some fall asleep and take a nap, all right? But they have to sign that consent form. I understand every time they go, no? Or is it, maybe it's in the file.
I see them when they're in the hospital primarily.
In the hospital setting, so they have already signed
They already signed for
all the
their
consent.
here.
Yeah, which covers everything. It's a blanket cover. I know that these centers, there are these dialysis centers that are scattered throughout the city, right? They don't have to be necessarily in a hospital setting, but I know that they do have to have the staff, the medical staff available on call in case any one of these patients does go into cardiac arrest. Because I have a friend who was on dialysis, and every now and then I would go visit her or take her to the place. And they have also typically associated with these centers is the clinic of a nephrologist who is also on call in case something goes wrong in the center. They're right there, next door, whatever.
Is there a nephrologist who prescribes the dialysis?
Actually, the formula for the actual regimen for the patient, yes. Okay, I may be dating myself here several years ago, but from what I knew, typically the regimen is 1 day on, 1 day off. So they go 3 times a week, for example, Monday, Wednesday, Friday, and then they have the other weeks free. Or it could be Tuesday, Thursday, Saturday, right? And they have 1 day on, 1 day off. They can be on the machine anywhere from maybe 2 to 4 hours, depending mostly on their weight, on the body mass, because you have to do a ratio, of the body mass. Maybe that protocol has gotten better with time.
It's about the same.
It's about the same.
There's anywhere from 3.5 to 4 hours.
Yes, that's the average. Mhm.
It is painful, the part when they have to access, if you have an access, you have an actual shunt. So what they do is they use topical lidocaine to numb the area because the needles are big.
Yes, it's a large bore needle.
But a lot of patients they just have a catheter, so it's not painful.
Right. If they're repeated patients, right, they will have eventually put a catheter on or a shunt or a line. This friend of mine, she had a shunt on her arm, and so that's the point of access. But anyway, it's cumbersome, it's debilitating. It's debilitating. They are, and typically they spend the off day recuperating from the treatment, okay? And so it does impinge on lifestyle. If they're young enough, they're able to tolerate it and they can go back to work maybe the off days, but otherwise they have to go on disability or something like that. So it's really debilitating. And what I'm trying to point here is that overall dialysis actually substitutes the kidneys. It's not just assists in the kidneys, okay? So functionally, dialysis substitutes the kidneys. If you think about that bioethically, it means that a patient who may qualify for dialysis may refuse dialysis ethically, which means they're going to die, essentially from poisoning, all right?
Or they can also choose to stop dialysis. right?
Exactly. And even once they're on, and that's the more typical case, once they're on for a number of years, they haven't gotten the transplant, maybe they don't qualify for transplant, or they fall off the list, or they're very low on the list, any number of reasons. Some people actually refuse a transplant because they're queasy about the operation, about the transplant operation, and they just don't want to go through it, even if, well, I don't know if for the recipient it can be laparoscopic. No, I don't think it can be laparoscopic for the recipient. I know for donors it can be laparoscopic.
Is it ethical problem or not?
I'm sorry,
Is it ethical to refuse?
yes, that's what I'm saying. Precisely because the dialysis machine is substituting the kidneys, then it is ethical to refuse it for a person who is an excessive burden. In this particular case, this particular patient, I feel that over the years now, this has become an excessively burdensome process for me. And therefore, yes, yes. And I'll give you the actual directives. When we get to the case, I'll give you the directives on the ethical and religious directives for Catholic healthcare services that states the exception where this, under which this falls, okay? Let me see a question here from Drisel. Able to refuse if they negative outweigh the benefits. Yes, basically it is. So Drisel is asking, I don't know if you can see it's so small, if under what circumstances essentially will the dialysis be refused? She's saying, wouldn't they only be able to refuse if the negative outweighs the benefits? Right. So in the burden benefit analysis, right, for this particular patient, it is excessively burdensome. And that's actually the wording on the ERDs, that this particular procedure has now become excessively burdensome for me in my circumstances. It could be for a number of reasons. It could be advanced age. It could be that the person is beginning to lose lucidity. They're going into Alzheimer's or something like that. They're just too exhausted after the process. It's excessively debilitating. They see no purpose in it. So subjectively, they would need serious reasons, but serious reasons can be there.
Like
Right.
if you have a, let's say, a 95-year-old person.
Oh, yes, exactly, because
You put them through dialysis.
exactly, that's right. You have to consider, right, typically old age would be one of the big qualifiers here, but also debilitating illness. It could be that the person develops another illness. Let's say they develop cancer in the meantime or something like that. All right, then they have a comorbidity moving forward that may be lethal. So what I'm trying to say is that precisely because dialysis substitutes the kidneys, it may be ethical at some point to refuse it, and it's okay. All right? Okay, so that answers the question. Let's move forward and look at another case. Let's look at the lungs. So that involves the kidney. With the lungs, we have two types of intervention, medical intervention. One is the respirator, the other one is the ventilator. And they're a little counterintuitive, the words, okay? Some people think that the respirator actually makes the lungs breathe, but they don't, they assist. It's assisting respiration, actually, it's assisting breathing, all right? So the respirators, there are different types. I'll show you the three basic types of respirator, but they're only assisting with providing enriched oxygen. But the lungs are doing the bulk of the breathing. Whereas the ventilator actually is direct infusion of oxygen to the lungs. So the ventilator, depending on the settings, may be assisting or substituting the lungs. The ventilator can actually breathe on behalf of the lungs and can actually make the lungs extract and expand and contract by a bellows, by a mechanism that it has. Okay, so the basic difference for now is that respirator assists the lungs in breathing, but the ventilator may substitute the lungs. And therefore, when it substitutes, it may not necessarily obligate. These are people who are intubated, like, for example, Terry Shiro, which we'll look at that case in particular in detail. All right? So you see the complexity building in here. All right, so let's look at the easy case of respirator first. There are these three basic types, but you can see they all go either to the nose or to the mouth or both. The easiest one is this little nose tube, which is just in the nostrils, and it's only providing oxygen, pure oxygen, all right? So it's enriching the breathing of this person, but it's external. And this little tube will be connected to the wall, typically in the hospital, or to an oxygen tank, right? But it's just enriched oxygen that is provided to the nostrils typically. It's the simplest case.
An oxygen cannula.
Oxygen cannula is the name? Okay, thanks. Yeah, cannula is a reference to the tube.
And then you adjust the
Oxygen.
amount of oxygen you want to deliver.
Oh, yes?
So it could be
It's regulated.
2 liters, 3, 4, up to 5 liters you can do
With a
with a
cannula.
cannula.
Wow. Okay. All right. So down to the level of detail. If the person needs more assistance, then they can do a loose mask that covers nose and mouth. But this mask is also, it's not sealed tightly. In fact, it typically has some holes or vents on the side so that there's a mixture with the ambient air. But this one can input more oxygen, I presume, and it also provides to the mouth, especially if the person is unconscious. So if the person unconscious, typically we open our mouth and we start breathing passively through our mouth so that it covers both nose and mouth. Okay, it's a little more assist, but still only assisting, not substituting. The third one that I know of that is the most intense is one that seals around the mouth and nose, around the face. And you can see that it's strapped down in two places so that it's sealed tightly around the mouth and nose. And then there's more forceful provision of oxygen here. But it's still only assisting. It's not, this cannot really force the lungs to breathe, fully. So these are all types of respirators. Different is the ventilator. Because I have a ventilator, get involves a machine, and maybe this machine is also outdated, doctor, it's probably smaller now.
This one is the newer version.
This one on the
That
right?
one is an outdated.
The one on the left, this
That
one.
one is good. Is a
Oh, this is more, oh, okay, yeah, I can see it's smaller. So yes, okay, this one is the more contemporary one. All right, so this machine basically substitutes the function of the lungs, particularly in the pressure. The pressure of oxygen that is inserted through a tube, a cannula, that will go into the lungs themselves. So you notice that at this point, the nose is irrelevant. The nose is bypassed and directly through the mouth, through the throat, into the trachea. Not the esophagus, because the esophagus goes to the stomach, right? But through the trachea into the lungs. And so this patient is receiving oxygen 100% from the ventilator, and the settings are regulated here, okay? So that this machine actually substitutes the lungs functionally. Is forcing oxygen into the lungs and is also providing a breathing mechanism, if you will, a breathing pulse, all right, of expanding and contracting the lungs so as to make those alveoli functional inside the lung themselves, okay? So typically the regimen, as I know it, is when a person is first put on a ventilator, we'll go initially at 100%, and then right away they start what is known as a weaning process. The weaning process. Oh yes, before I talk about that, how do they monitor this? Well, they monitor it by a thing called perfusion. Again, doctor, correct me if you're of course here, but perfusion is essentially the amount of oxygen that we have in the blood, and that's measured by this little magic machine that they put
pulse
in.
oximeter.
Pulse oximeter?
Pulse oximeter.
Pulse oximeter, there you go, okay. And I understand.
Actually, some patients have an arterial line. So
Oh, yes?
Yes, it's a catheter that goes into an
Wow.
artery.
And all the vitals can be monitored there. tremendously. Okay, so again, the advancement of medicine here. But this oximetry, what it measures actually is the saturation of oxygen in the blood, the percentage. And what is a normal, typical saturation is above like 98%, right? It's like 99, 100%. That's pretty high, consider 98, 99. So I understand that if the machine goes below like a 98 or 97% of oxygenation, that's already danger, okay? And they have to readjust the setting to put more oxygen in there. So it's really a very, very high setting, because I say this because, again, when I go visit some people who are in the ICU and they're all hooked up and I see all the monitors, sometimes these will start dropping 95, 90%, and then the alarms go off and all the medical team comes, or at least the person who's monitoring this machine, right? The doctor or technician, and they'll assess, adjust the setting. But right away, it's a very dynamic situation. This requires, which is also labor intensive, right? Because they're monitoring each individual patient to see how well are the lungs responding to that treatment, and if they can start weaning the person off the machine. So that if the blood is perfusing properly, then they'll try to tone down the ventilator to see if the lungs respond. Again, Monica, you're the nurse also, so am I on the right track? Have you done?
I have not worked directly with
Not in ICU?
it. No, I
Okay.
haven't in ICU, but
Okay, but you know the background to it.
Patients.
You have, yeah. Okay, so this weaning process is very interesting. It's a dynamic situation whereby the patient is monitored continuously to see if the lungs are responding or not. If they are, then they start toning down the machine.
So they put the tube in the mouth.
Through the mouth, yes. Through the mouth, down the trachea, down the vocal cords, through the vocal cords, down into the trachea, into the lungs.
And why do some people, they open like a little hole?
Yes, because this machine normally can only be made through the trachea for about 2 weeks, actually. I know a patient who stayed for 3 weeks, which was extraordinary, but it saved her life. But the normal protocol, I think, is about 2 weeks. After that, it would be permanent damage to the throat, and therefore they have to extubate and make the tracheotomy, which I have in the next slide. I'll talk about the tracheotomy, which is that hole underneath the vocal cords, right? It goes directly into the trachea. Okay, so what I wanted to point out here is that if the weaning process is successful, by the time they get the machine down to about 60 or 50%, I think, that is the protocol calls for extubation. And then see if the patient continues to breathe on their own, because by the time the machine is at 50%, it means functionally that the lungs are functioning at least halfway, all right? And what they need to do is see if they can pick up the other 50%. And so that's the weaning process, all right? And typically, I think the maximum is about 2 weeks, really. Then, if the patient is not responding yet, because let's say that the patient has pneumonia, right? And they will go on antibiotics. They also typically do an induced coma, so they slow down the metabolism to quiet the person down. Of course, it's very uncomfortable to have tubes through the nose, through the mouth, and into the lungs. So the typical patient, they want to pull these tubes out, which is not a good thing. It's a whole technique for pulling that tube out. And so they are sedated, right? And they're given somnifers and muscle relaxant, and it's a whole cocktail of things, but to keep them in an induced coma. All right, if they don't respond, if the lungs don't respond, and they have to keep the person intubated on the ventilator for a longer period of time, then they need to do what is known as a tracheotomy, which is a hole in the throat, below the lower throat, going directly into the trachea and bypassing the whole throat region. Okay, so that unfortunately damages the vocal cords somehow. and then they'll have difficulty talking after that. But people have survived, and they can survive a tracheotomy. The hole itself is called a tracheostomy, all right? And they will use some kind of a scarf or something to protect them, because that's an opening directly into the lungs, all right? And so you don't want to get bacteria, or even, well, I don't know that this would actually filter bacteria, but particles, dust particles, or anything down that trachea is a complicated thing. So there are little filters that they can put on the neck to protect the opening, but it goes directly down the trachea into the lungs. So that's the tracheotomy there, all right?
And I read once that they can form biofilms
Yes,
in the tube. So
exactly. Exactly, it has to be
Yeah,
monitored.
colonized with bacteria.
Mm-hmm. Yeah, so they need to be monitored and cleansed. Again, they have a whole,
They have to be suctioned also.
they have to be suctioned for mucus that is produced. So it's complicated, it's difficult, but I've seen people even in mass who have a tracheotomy, and they were able to have some kind of a lifestyle, you know, kind of normal lifestyle. What I want to say about this is that once the tracheotomy is done, the vent can be hooked up essentially indefinitely. And a person can be maintained on a ventilator. Say, for example, the classical case is a persistent vegetative state, right? Trauma to the brain, but the person is still breathing, or the heart is still beating on its own. And so the person can be maintained essentially indefinitely for years and years. They will also have nutrition through parenteral nutrition. And so this is a big issue, because now we have this persistent vegetative state. And that was precisely, sorry, it was not Terry's case. She was not on a ventilator, sorry. She was not on a ventilator. That was precisely the bioethical issue with Terry. Because the ventilator at this point definitely is substituting the lungs, okay? And it doesn't really obligate. So once we go into this kind of situation where the ventilator is through a tracheotomy, then it's substituting the lungs. It means that the lungs are not doing anything. Okay, so you can see that bottom line for the ventilator, it really depends on the setting. If the ventilator is assisting or substituting the lungs, okay? And the settings themselves depend on first the diagnosis, what the person is being treated of, and then the prognosis, the hope of recovery, the overall health of the patient, and the prospect that this patient will recover with a round or a regimen of ventilation. Yes?
They call those patients ventilator dependent.
Yes, okay, ventilator dependent?
They need the ventilator.
Indefinitely, 100%, right.
Ventilator
And-
dependent, the patient is not breathing on their own.
That's right. And that's long-term typically, right? Yeah. Okay, so you see that presents particular bioethical issues for the patient and for the surrounding people and the family members and so forth, and even for the institution with regards to cost and so forth. All right, let's move forward then. Let's look at the heart now. Again, the issue here is resuscitating the heart, right? CPR. Keep in mind that when the heart fails, naturally, that is a vital organ that has failed. Okay. So CPR, cardiopulmonary resuscitation, may be assisting or may substitute the heart, depending on the setting and the particular circumstances of each individual patient. Part of it is what is the prognosis, what is the hope of recovery. My father, when he was young, was a smoker, and we were living in Mexico City at that time. Remember, my brother and I were teenagers. My parents must have been, well, my mother was 13 years older than my father, but dad must have been about in his 40s. His dad had died from a heart attack at 65, my grandfather, and his grandfather had died of a heart attack also, so he was definitely on the line. And he was in his 40s, and he had a big scare one day at a meal. They were having it was a large meal with a bunch of friends and so forth. And at that time, one could even smoke in restaurants and everything else. It was, today, it sounds so bizarre, you know, but I've seen pictures of people with a fork in one hand and a cigarette in the other hand. It's unbelievable. Today, that's totally bizarre to us, but I lived a time of that life. At any rate, he collapsed and he was short of breath, and so they did CPR on him. You know, but he was in his 40s, and they brought him back. Thanks be to God. He ended up dying from a heart attack at 65, after he had quit smoking for over 20 years. But other pressure got him. Anyway, so but he survived this because of CPR. He was young and so forth. But when it could possibly substitute the heart, CPR would be a patient who is, again, in their 70s or 80s. Our bones become more brittle as we grow and as we age. And in women, even more brittle because of the extra loss of calcium. What happens is that CPR on the aged many times end up breaking the ribs because of the compressions. And now you got broken ribs, and some of those ribs can also perforate the lung evenly, puncture a lung, then you have even greater issues. So an 80-year-old with broken ribs the ribs have to seal on their own. You know, there's no cast or anything like that for it. It's painful, prolonged. So what I'm trying to say is that under certain circumstances, CPR may be considered extraordinary, may be considered coming back to life of an organ, of a vital organ that has stopped on its own, that has failed on its own. So we may allow the heart to stop. We didn't stop it, you know, it stopped on its own, and there was a reason for it. So that could actually be the death process for this person. So I'm saying that CPR may be substituting the heart at some point functionally, which doesn't obligate, and that's when we have this famous DNR orders, do not resuscitate order, is directly do not do CPR on this person, do not resuscitate. Sometimes the CPR is done by compression, the other in a clinical setting, the CPR can be done with the pads, okay? And then we have this other type that also gets the heart going, again, the defibrillators. We have an AD right down the hallway here, okay? They're all over the place now. These defibrillators they send an electrical current, an electrical pulse through the heart to try to get it back into its normal rhythm when it goes into arrhythmia or some or tachycardia, which could lead then to the heart attack. So again, these defibrillators could either assist or substitute depending on the circumstances of this particular patient. All right. So the heart and heart failure very much depends on what is the circumstances of this particular patient in front of us here and now. Okay. I understand that the standard protocol, for example, if one calls 911 and in the ambulance, that they will resuscitate. The standard protocol is to resuscitate.
Unless they have some sort of identification or somebody knows that they have
a DNR, right? Okay. So the next of kin, or if they fall unconscious, can speak on their behalf. So it's a very fast and quick decision. But what I'm saying about this is really that these conversations need to happen before, when we're all healthy. You know, if I were in this kind of situation, would I want to be resuscitated or not? Okay, so this is the kind of conversations that we need to have in our family beforehand, when we're all healthy. And even sign those later in another lecture, or actually give you a Catholic living will, a Catholic statement of life and death that is according to the teachings of the church, and actually appoints a proxy to speak on our behalf and so forth when something like this would happen to us. right? Not now, but much later in life, of course. But, you know, sometimes or at some point, we're going to typically fall unconscious and someone will have to decide for us. So we're going to look at another lecture, the whole issue of consent, informed consent, and then proxy consent and so forth. Okay, so just to recap then, what today's lecture was about, we looked at the vital organs of the body, okay? And associated with that, the distinction between assisting or substituting vital organs, which is in principle a philosophical decision, which then is a bioethical decision, right? And then the practical conclusion that there is no obligation to substitute vital organs, but there is an obligation in principle to assist vital organs, because that is what we call standard care or ordinary means of life support, ordinary means of life support. Okay. Then we're going to go into more detailed cases, including nutrition and hydration and so forth, and also looking at the ERDs. So this is a good time to review that part 5 of the ethical and religious directives. I don't even know if you have them. Did you get the ERDs, the ethical? No? All right. This is a good time to introduce that dialogue then. So let's look at this for a moment. Ethical and religious directives. If you just punch in those 3 words, you get the link, all right? And just recently, so this one is outdated, because there's a new edition, which is the 6th edition, which was just published last year, because this one, the previous edition is from 2009, but we actually want the 6th edition. Sorry, so let me go back a moment. Yes, oh really? Okay, yes. Yes, and this one you can download for free also. And, or if you want to order it, let's see if this one gets me to the actual site. Yes, there we go, exactly, that's where I wanted to get. So here we go. This is the official website of the United States Conference of Catholic Bishops, otherwise known as the USCCB for short, right? The USCCB, and this is the official site. And within the site, this is the actual link to the directive. And you can see this is the new one, the 6th edition, 2018, all right? Together with some colleagues, we worked on this document on consultation, and it's very exciting because it comes both in English and in Spanish, and it has 6 parts. It's actually almost like a booklet. It's only about 40 pages long. Oh, yeah. And it's long like this. I should have brought one from my office, but you can see that you can download it for free from the internet, or you can order it. I think it costs about $3 or $4 for the one little brochure or booklet. It has 6 parts, okay? And part 1 is the social responsibility of Catholic healthcare. First of all, we need to know that in the United States right now, Catholic healthcare is about 10% of the total healthcare in the United States, okay, which is a significant number. We're very proud of that, but it's also a tough thing in the sense that there are certain procedures that are offensive to Catholic teaching, and therefore we need to abstain from them, and that puts us at a disadvantage in a competitive world that even medicine has been commercialized. So, for example, the in vitro procedures, which are extremely profitable, we take exception to and we don't do. So that puts us at a disadvantage with other hospital systems in the area, for example. And also at the end of life already, about 8 or 10 states in the United States have already legalized physician-assisted suicide, legalized. And we would take exception to that too, so that puts us at another disadvantage at the end of life in hospice situations and palliative care. So you see that by maintaining Catholic principles, we are at a distinct disadvantage in the competitive world of medicine, in the practice of medicine. Anyway, so the social responsibility. Then part 2, pastoral and spiritual responsibility. Let me see if I can make this bigger. It has to do with mostly the sacramental, having the sacraments available for patients, right? Whether they're Catholic, for the Catholics, and if they're not Catholic, to try to get them the pastoral care that they need, whether they're Protestant or Jewish or Muslim, whatever. Mm-hmm. Part 3 is very interesting. Part 3 is the patient-doctor relationship, all right? Or professional-patient relationship. It's of mutual trust and respect that is built there. Then 4 and 5 are the ones that pertain to this course. 4 is the bioethical issues at the beginning of human life. Here you'll have in vitro and abortion and all those issues that we talked about. And now we are here at the end of life, care for the seriously ill. So you can read this part. And then finally, this is the part that was mostly worked on from the last edition in partnerships or collaborations, because this involves the principle of cooperation, material cooperation, formal cooperation, especially when we're now going into systems where we have Catholic hospitals associating with non-Catholic hospitals, and what may be allowed and what are the limits of that cooperation so that it's ethical for the Catholic hospital to engage in those associations or collaborations, okay? So that's mostly part 6. And this points out that this is at the institutional level. So it's a little different when we get to, it's not as rigorous at the level of individual material or formal cooperation, but this is at the institutional level. One element that is bigger here at the level of the institution, for example, a Catholic hospital, is the whole issue of scandal, right? If a hospital were to do certain procedures that are offensive to the Catholic Church, then that could cause scandal in a good sector of the population. So that's a high flag there, is a high risk. Anyway, back to part 5 here, just to illustrate it for a moment. The typical way that it's done is that, it's a little too big. Each part, you can see it as a chapter, chapters 1 through 6, all right? And the first part of the chapter is an introduction, and it's just a narrative that states the basic principles that are involved there. I go to end of life here. And then the second part of the chapter is specific directives, which are numbered. Starting with the first chapter, number 1, and ending with number 70-something at the end. So it's about 70 directives. That's professional patient, and it will be beginning of life. Now here we go, end of life. All right. Part 5 is the one that pertains us now. Again, there is that first section of the introduction, stating basic principles of the dignity of the dying person and so forth. And then we start with specific directives, you see? And you will have a number of these directives. These for the end of life are in the 50s and the 60s, the numbers. Mm-hmm. So you see proportionate means or ordinary means are, they obligate, but extraordinary means do not obligate. They may be foregone, all right, ethically. And that's what we're going to talk about a little bit more in detail. Then talks about nutrition and hydration and so forth. So it's about 8 or 10 directives that are involved in here, okay? And then it goes into that collaboration thing. So part 5 of the ERDs, this document is known as the ERD for short, Ethical and Religious Directives, yeah? ERD. Just make sure that if you go online, you get the 6th edition, which actually the only section that's changed for the 6th edition is that chapter 6. But so even if you have the old one, chapter 5 will still do for this course. Okay. I should have introduced this literature actually at the beginning of Life Issues, which I didn't. I just totally forgot. But it's never too late. You can get it. And also, if you order it, it comes in a little, let me just go over to little talk about it. Let me show you one.
I need higher socks. This wouldn't do it. That's how I pushed me to do this master's. This part, yeah. As I was discussing last year, my father was, I heard he was dying, and I had a visit of a nun friend of mine. She's a religious, consecrated Franciscan nun, but she lives in the community. She works out, and then we're very good friends. And I was telling her about my father's that we had made him a DNR. And then she says to me, but who are you to withhold, participation from him? And it's like, am I been doing wrong all these years?
Like, I don't know. Who am I?
So I felt it's like she made me hesitate my own understanding for what it was to allow my father to die with dignity or any other patient of mine. And so I went to speak to father about that. And then he told me my father was 97. He's at that end stage cardiomyopathy. And I mean, what? And then he went a little bit of this, and he said, no, you're not wrong. Why is being on? So then I went to a conference, and then it was the booth about the masters from St. Thomas. And I said, okay.
Did you end up talking?
No, I haven't. She doesn't know that I want to surprise her.
Thank you.
I have one, yes.
Okay, you probably have the 6th edition?
Yes.
Okay. Sure, you're welcome. Anyway, you can start looking at it. Right? It's very useful and succinct. In other words, it gives us the teaching of the Catholic Church in these little directives, and each directive is very much to the point. So we'll be talking about them more and more as we go along. Okay. So for now, you can start doing some reading there on part 5 of the ERDs. Okay, so that's really all I have for today. And now next week, we're on spring break, all right? Which means we don't have a class next Saturday, but then in 2 weeks, we'll meet again. So next
Some
Saturday.
cases that I'd like to share with you.
Yes? Oh, sure.
But I don't know whether it's now or just to illustrate some, maybe I can just.
Okay,
tell
yeah.
you one.
Absolutely, yes,
I have a patient who is, she's probably in her 80s. She has advanced Parkinson's, end-stage Parkinson's disease. And she's deaf. She has been deaf for a long time. And then she has dementia, advanced dementia. And I've known her. She was my patient. Actually, I'm the one who sent her to the neurologist to be diagnosed with Parkinson's.
yes.
And she was about maybe about 10 years. She walked into my office. Okay, and over the years, I've known her.
So you've been following her for about 10 years?
Well, I found her again at this rehab center where I
Oh,
work.
I see. Okay.
And she was my patient there too.
Ah,
And
okay.
I've seen her progressing.
Yes.
So the thing is that her son is a social worker. And
Right.
she has progressed to the point that she's completely bedbound.
Yeah.
She's contracted.
Yeah.
Moving her is very painful.
Wow.
They are not addressing her pain.
Oh.
The son doesn't want to give her any other, stronger pain medication. Then she went into the hospital with an aspiration pneumonia, severe difficulty swallowing. He put a feeding tube on her.
No.
And then she has peripheral vascular disease that she has to ulcerate in her heels. So
Exactly.
there's nothing that they can do for her.
The cubitus. Mm-hmm.
So to me, that's very cruel.
Yes, that's exactly right.
And
Yes,
he still has not made her DNR.
really. My goodness. I assume that he's the one who's the proxy, right? Yes. Yeah. Exactly. Yeah. That's a very, very challenging case because what is best for the patient, right? It's like he's obsessed with keeping her alive. But at that point, what we do is we ask the question with the PEG, which is the feeding tube, all right? And that was the crucial moment of decision there, because without that feeding tube, of course, she would have continued to decline and then keep her comfortable until she would actually die. But now the feeding tube keeps her alive, in principle, again, indefinitely. But what the big question to me is, what are we prolonging the life or are we prolonging the death of this person? Because she's totally unresponsive, she's contracted a fetal position in pain, and now she's developing these ulcers, which are bound to enlarge, get infected, they're also painful. So it is cruel. It is cruel.
Yeah.
Yeah.
My heart aches every time I
Yeah.
see her.
Yeah.
Because just to move her, she screams,
Wow, exactly. Yeah, she's so sensitive. She's hypersensitive to any touch, even just touch, because her body is responding.
So I feel
Yeah.
compelled to ascend to speak to him.
Yes.
And then I almost had a heart attack when I found him being part of the bioethics
Wow. Oh my goodness.
hospital.
That is assessing her. Oh,
So
for
it's
the
like-
whole hospital.
for the hospital where he worked. And
Yes.
he's like, I would feel like he would know better.
Exactly.
Like you guys, he within the multidisciplinary team saying,
Well, the
the
thing is,
nutrition,
Mhm. Yeah.
when she goes out to the hospital and then the decisions are made in the hospital. She
Uh-huh.
come back to our facility.
Rehab. Mhm.
Already there, like with PEG, and it's like,
Yes.
can you believe it when she comes back with PEG and they
Yes.
let her go,
Right.
So, and she's
Yes.
still there.
Yes, yes. And now the burden is on the rehab facility to do something with those ulcers, right? Because now the institution is going to get dinged for those ulcers and the care of that, which was brought onto you to that institution because of a bad judgment, really. It's, I mean, of course.
like, is he following the directives? Did she ever have an established? Is he following?
No, she just slipped into this, she progressed into Alzheimer's, right? And so he's the natural caretaker. Yeah, very, very tough. Probably has a court appointment or
He has
something.
an issue understanding.
Exactly.
He
The
feels
problem
no,
is with
that,
him.
That it's like, if
Yes.
I say no, I'm letting her, I'm allowing her death, and if he feels compelled
Right.
to keep her alive regardless.
Yes.
So
Invite him
I
to this
think-
class.
I think he needs to be that is going to feel right, and that is a
Yes.
conversation that a lot
Yes.
of people have. I mean,
Yes.
I live this every day in the nursing home
Yes.
because I see this end-stage dementia with
Mhm.
meetings that they
Right.
stay there because, and the family still have not made it DNR.
Right.
End-stage dementia, they do not have any interaction whatsoever, total care
Right.
with
Right.
feeding.
Yes, yes, yes. It's very hard. And that's what the crucial distinction here from the bioethical perspective is killing or allowing to die. That's going to be the bottom line of this second half. Are we killing or are we allowing to die? We may not kill for sure, but if we don't allow to die, we're being cruel because everyone has to die sooner or later. And the problem is that sometimes the death process is subtle, but it's real. The death process has begun. If the death process has begun, for heaven's sakes, we need to allow that person to die, to complete the death process, because otherwise, if we don't, we're prolonging their death. And that's a cruelty. And the church is against that, all right? But it's very misinterpreted a lot. And that's where we need to focus in on this issue. Are we killing or are we allowing to die? We may allow to die the patient, because then what needs to kick in is comfort care, precisely. Comfort care. But there's nothing more that can be done to the patient. Therefore, a PEG, just like the ventilator, may be considered extraordinary at some point.
It's substituting.
It is. It is.
The intake of
Right.
her on her own.
Exactly.
So we're substituting.
Yes, it gets a little subtle because in principle, nutrition and hydration are ordinary means of life support. But precisely, the key word here is in principle, meaning that there are exceptions. And we'll look at those. Those are a whole other lecture that we'll get into, but we'll devote a whole lecture to nutrition and hydration precisely because it's so delicate with the PEG and the NG tube and so forth. Yeah. All right, but these are the issues that are coming up. So for this person, the social worker, we don't know if he's Catholic or not, but it seems like he doesn't want to, he feels guilty about killing his mom, right? But the point is now he's torturing his mom, objectively speaking, looking from the outside. He doesn't see it that way, but he's actually torturing his mom.
He doesn't see it. I mean, he comes for a little bit, visits the mother, and then he's gone.
Exactly.
Stay with the patient,
Exactly.
And it's the entire
situation.
Yes.
They also, the other thing is you have to consider what they're bringing psychologically from their whole relationship with that person. You know,
Yes.
there could be things that
Yes.
you feel guilty of in his past that is part of why he can't let
There's
go.
a lot of subconscious projections that can go on.
And that's
Absolutely,
why
especially mother-daughter or mother-son. Mother-son situation could be a situation of guilt, and therefore it can be pathological. So it's a lot of things there. Not just because the person is an adult does it mean that they're going to think rationally and what is best for the patient. Many times in these cases, we end up doing what's best for us because we either the two extremes. We don't want to see the person suffer, or we want to put them out of our misery, not out of their misery. So we have to be careful. It's subtle, but it's real. To me, it's all about determining, is the person dying? You know, have the vital organs begun to fail here? Then we may allow the person to die, but to die in peace and not torture that person. So that's the key question. Is the person actually dying? What's the prognosis? What's the hope of recovery? For here is nil. She's gone. Exactly. So what are we doing to this patient, right? Yeah. So how to approach her son, this individual who has a certain part of denial in his life, right? He's denying that his mom is dying, actually. What he needs to accept is that his mom is dying, and what he's doing is prolonging his death. How to approach that individual, this is where the pastoral team has a lot to do. It's very useful, the pastoral team, the pastoral care, because then that individual is not listening to clinical stuff. He may be open to listening to, on the spiritual side of things. Let's say hypothetically, if he's Catholic, there's a pastoral care team, a priest could approach this man and sit with him one-on-one and say, look, this is what's happening with your mom. So she's actually dying. Here are the documents of the Catholic Church that say that she's definitely in extraordinary means, that there's no obligation to do that. Here is the document, the official document from the bishops of the United States stating that you may let her go. You may allow her to die, okay? If you were Catholic. If it's not Catholic, it doesn't matter. I think that the arguments still hold because these are not arguments of God or religion necessarily. They're arguments of nature and what is reasonable. Vital organs failing irreversibly, death has begun. They're failing irreversibly. Death has begun. Okay? So I don't know if somehow in a professional way you can find out how this individual can be helped, this son can be helped to understand that his mom is definitely dying and that what is being done to her right now is cruel. Maybe, does he have siblings? Does he have someone else that is an important person in his life that can approach him? And I'd be happy to talk to him if you want to give him my number. You know, I always do this. If at some point you see an opportunity for him to talk to someone in the know, I can explain this from a spiritual perspective, right? I'd be happy to talk. Many times people call me for these kind of consults. This is what we do. Yeah, but if we could get him to realize that his mom is dying and that she needs to be let go, that's really what it comes down to. Okay, so you have illustrated the point that this is a very real situation, that we focus on these vital organs. If they're failing irreversibly, in this case, the brain is the main one, and collateral is also her digestive system, right? Then we may allow these people to die in peace, right? To die in peace. Okay.
Now that the Cleveland Clinic, they also have an ability, you know, they use this ECMO.
It is what?
The machine.
Oh, yes.
That can keep your heart
Right.
going. And
Yes.
So
Yes.
she was, Laura was saying how that's opening another whole
Area of
issue
bioethics
because
there.
Then they
Right.
put them on, and then it's like,
Exactly. Yeah.
okay, when do you take one, do you take off?
That's right.
You know, what's going on.
Yes.
And
You have to look at each patient in the whole situation, the whole structure, like you say, including their social structure. But to me, what's crucial is the prognosis. What is the hope of recovery for this patient, right? In their condition. And keep in mind, we haven't even talked about finances and law, which are two other big, huge aspects of this, okay? Because think about this. At an institutional level, if it can be coded, then the institution is billing for maintaining this person alive on these machineries, which are sophisticated and therefore expensive, right? So in the meantime, the institution is billing for that.
it's so expensive.
Exactly. But then, so that's a source of income for the institution, all right? Number two, because of legal exposure and the possibility that an next of kin can come back and say, oh, you didn't do enough for my relative to save their life, here's the multi-million-dollar lawsuit because of the deep pockets. For legal reasons, sometimes the temptation at the level of the institution is to do extraordinary means because they have the capacity to do it. And if it's a standard protocol, like for example, dialysis, you better believe they're going to be put on dialysis, because otherwise it could be medical neglect or an exposure, legal exposure to a lawsuit. So those two drivers, on one side, getting income from the extraordinary procedures, on the other side, protecting themselves that they did everything possible, even the extraordinary, to keep this person alive, minimizes their legal risk. So these are two big factors that play in, and they not necessarily play in well with what's best for this particular patient. Yeah, and the real issues, you think that this is not happening in the US today, but it is.
Also, there is a factor, like the last bioethics committee that I attended, they did a case simulation. And
yes.
One of the issues was like a patient with cancer, he had failed treatments and he I think had one of the leukemias. I don't remember the pathology that he had.
Okay.
But one physician had worked very close with the family, and they have decided to withdraw life support because he had complications. He was in a ventilator, and he was, he was not responding. They could not bring him. And there was the time to make a decision whether to disconnect him or trach him and see if he would respond to if he could go with the treatment.
Right.
Because there might be a small possibility.
Right.
But he didn't qualify because he was sick to any further chemotherapy treatment.
Right.
So then there's a physician that is working with the family, and they have a good rapport, and they have decided to wait for other family members to come.
Right.
Unfortunately, that physician wasn't working the day that they were supposed to disconnect.
Oh, wow.
And then whoever comes on board, then speak to the wife again and tell her that there is a little bit of there's a line there
that little,
might qualify for this extraordinary treatments for this cancer, and it's like, and then she was
They
like,
change the mind, or
change the
they,
mind.
right?
So it's
But
like-
it's the day of the trach, right? The day that they have trach, so
they have to decide whether
exactly.
to
You
walk
load the
in or-
bases and, right, and what to do.
So they didn't have parking?
It was a
Hypothetical.
hypothetical case.
Okay.
Yeah, these are exercises for the bioethic committees in institutions. Periodically, they'll have a case, a hypothetical case, in which to work to see how the team interacts on the medical side, on the bioethical side, and depending on the institution, sometimes if they have a pastoral care, the priest or whoever is the director of pastoral care will be brought in also to be part of the team.
It's so difficult.
It was so difficult because it's like,
Exactly.
what do you do next? Now
Yes.
the wife is again at this point where she's hesitant because somebody
Mhm.
came in and gave her like, maybe you're just going too quick now to make a decision. And
Right.
further opportunity.
Right,
On the other hand, the poor man, is like dying.
exactly,
He's doesn't have a chance.
He's
He's
not
so
responding.
irritated from the cancer. He
exactly.
got septic versus heart failure, he's an event. And
Multiple.
the other
shutdown.
doctor who knows the case who has been taking care of, let's say, Monday to Friday, she knows, and she has Friday and nothing has Friday. So it's like, who do you connect to give
Right.
advice to this woman? What is the best decision?
Exactly. Yes. But psychologically, and that's what's so difficult is that typically the next of kin, which are the people who have the legal responsibility, right, but also the vested interest in keeping their loved one alive, they're not necessarily the ones to make the best decisions sometimes because they're emotionally engaged. And what happens is no one wants to be the one who pulled the plug. All right, I pulled the plug on my husband, and so it's very easy to translate it into I killed my husband. I didn't give him the chance that he needed. Maybe he could have been saved if I didn't do that. Yeah, and this actually we go into fantasizing at that point. It's not realistic. It's not sustainable with the actual physical reality that is happening to this patient. And in my opinion, what this wife needs to know, sadly, is that her husband is dying, actively dying from the cancer, and the prognosis is 0. There's no hope of recovery.
Because even at that point, he's not at a stage that he will qualify to get that.
For that, exactly, that extraordinary treatment that could possibly, right.
Because I've seen it so many times. Even if they make it and they come out, they're
Right.
so debilitated that they
don't qualify then
for that experimental treatment.
Exactly right. Yeah, that is forever. Yeah. That is another challenge that I have found always now with the dialogue with medicine is that the medical profession is also, the practice of medicine is a statistical practice. In other words, it is based on probability. No doctor will tell you, well, you will recover or will not recover. They'll tell you you have a 90% chance or a 10% or a 50%, but it's based on probability. Statistical, based on previous cases. 90% of the people who went through this treatment, in your case, they succeeded, right? Something like that. But the problem is that we're not probabilities. We're determined individual human beings, and who's to tell us if we're in the 90% or in the 10%? Unless a statistic is a post facto thing, right? It's like evolution, it happened already. But we are already over here at the product end. And so we're determined individual human beings. And so we're going to follow that probability. That's the challenge, right? So it's always that tension between the probabilistic model and the deterministic model of the actual patient here and now. And that might be a good question for next course in a few weeks when we start at the summer with the statistics course. So how much credibility to give to these statistics? Because at the end of the day, it's a number. It's a number. It's a probability. All right. Well, thanks again. That's all I have for today. And we ended up a little earlier. I wish you all a very happy and safe spring break, and see you again in a couple of weeks. Also apologize. I just remember now I haven't had time to correct your homeworks from last time. So by the time you send me this one, you'll get 2 homeworks back in a couple of weeks. Okay. All right. You're welcome. Thank you again. All right, so I'm going to close it now. Bye-bye, everyone.